Hello, everyone, and welcome to Preemie Chats, a space where we connect, learn, and share stories about the world of prematurity. I'm Leah Whitehead, a proud preemie parent and former journalist, and I'm so honored that you have chosen to join us here today. Preemie Chats is brought to you by the Canadian Premature Babies Foundation, also well known as CPBF, a parent-led charitable organization dedicated to supporting families, advocating for the needs of premature babies, and providing the latest information and resources to help parents and caregivers navigate this journey. So whether you're a parent, a healthcare professional, researcher, or just someone interested in understanding more about preterm birth, you are in the right place. Together, we're building a supportive community where stories are shared, questions are answered, new evidence is explored, and no one feels alone. Be sure to visit our website. It's there on the screen, canadianpreemies.org. There you will find helpful resources, our latest projects, and most importantly, a community of people who want to see our babies thrive. If you're watching live, I'd invite you to please join the conversation. In the comments, let us know where you're watching from. You can share personal stories and you can ask questions for our guests, and we'll try to get to them during our program today. If you're watching a recorded session, you can still connect with us through our website. It's through meaningful discussions like the one that we're about to have today where we advance, practice, and grow together. So again, let us know where you're watching from today and any comments or questions you have. I hope you had a chance to join us earlier this week for our webinar on Respiratory Syncytial Virus, or RSV. It was an incredible time of learning and discussion, but honestly, and I said this then too, we really only scratched the surface of this very important topic. So that's why we're continuing the conversation today with this special edition of Preemie Chats. Joining us are two amazing guests, Dr. Tiffany Fitzpatrick, who will unpack how social factors like housing, income, and access to healthcare can influence a child's risk of illness and how severe that illness can become. And we'll also have Dr. Jessie Papenburg, who will walk us through what parents and caregivers can do to help prevent RSV in vulnerable young babies, and what immunization options are currently available across Canada. We're so glad you're here with us to keep this discussion going. We're going to start with Dr. Tiffany Fitzpatrick. She is a scientist at Public Health Ontario, adjunct scientist at ICES, an assistant professor in the Division of Epidemiology at the University of Toronto's Dalai Lama School of Public Health. She is also a member of the Centre for Vaccine Preventable Diseases and the Canadian Immunization Research Network, as well as the executive board of the Canadian Association for Immunization Research, Evaluation, and Education. Dr. Fitzpatrick's research primarily focuses on the use of modeling and administrative data to investigate the epidemiology and equitable prevention of common pediatric respiratory viruses, and particularly RSV. So thank you so much for being here with us today, Tiffany.
Thanks so much for the invitation, and thanks everyone for joining. I'm looking forward to talking with you today. I'm just gonna pull up the slides. Perfect. All right, so hopefully everyone can see the slides okay, and hopefully you can hear me okay. I'm gonna apologize now because very on point. My little one brought a cold home from daycare in her second week being there, so I'm a little bit nasally still, and hopefully I don't have to pause to cough or anything, but I appreciate everyone here could probably understand this situation. So today I'm going to be giving you a bit of a primer on what is the epidemiology of RSV. So what I'm talking about is the burden of disease, symptoms, transmission, and so on. But then most of the time I'm going to be talking about risk factors for what will put a child at increased risk of developing severe RSV illness. And in particular, I'm going to talk about medical, but mostly social risk factors. And then in case you need to step away or what have you, at the very end, I'll leave you with some key takeaway messages. All right, so I think most people probably aren't too familiar with RSV. Maybe people on this call might be, given the phenomenal job that the Canadian Premature Babies Foundation does with their RSV resources. And I also just wanted to put a plug in for that session that happened on Wednesday. It was really, really interesting, and it covered a lot of the topics that I don't think we'll have time to touch on today, but are really important for thinking about social inequities and RSV prevention. So definitely recommend you go watch that if you get a chance. Now, just to lay some basics here for the burden of RSV, you might be surprised to learn that RSV is the most common cause of respiratory tract infection in early childhood, and it is the leading cause of hospitalization. Now, in addition to that acute respiratory infection period, children that have severe RSV in the early life also have increased risk of developing other health impacts long-term, in particular asthma. Now, around the world each year, RSV places really considerable burden on not just the health of children and the health and well-being of their families, but also a lot of pressure on the healthcare system. So each year we see about 33 million respiratory tract infections due to RSV and about 3 million hospitalizations, and that's just in kids under 5 years of age. Now, 50% of kids will be infected with RSV before their first birthday, but nearly all kids will be infected by their second birthday. And I just wanted to take a second here to thank Jesse, because he shared some of his slides with me for a previous iteration of this talk that have been adapted here in a few of the other slides. So thank you, Jesse. So now, of those what we call primary infections, so the first time someone is infected, about 20 to 40% will go on to develop lower respiratory tract infections. That's a more severe type of respiratory infection. And usually that manifests in bronchiolitis or pneumonia. So a little bit of terminology here. They're both types of inflammation, bronchiolitis being inflammation of the small airways or the bronchioles in children, and pneumonia being inflammation of one or both of the lungs. So more severe forms of illness, and oftentimes they might require medical intervention, such as hospitalization. So what we see in a given year, I'm just going to show you some data here for Ontario, because this is the area that I work in. These figures are showing the number of hospitalizations in children under 5 in a given year, in a typical year. So you see here that the risk of hospitalization is really dependent on the child's age, with children that are really young during the RSV season being at the greatest risk of being hospitalization. So you see in this first figure, the green line showing kids under 2 months of age, the highest RSV admission rates. Slightly lower is 2 to 3 months, and then 4 to 5 months. And then you see on the bottom, it really drops off for the older kids that are 6 months of age to 5 years of age. So in a given year, we see anywhere between 2,000 to 2,500 admissions for RSV in Ontario typically, and about 6,000 in Canada. So really a significant number. And just to put that in context for how many children we're talking about that are born, that represents about 1 to 2% of all children under 1 year of age. So it's really, a quite burdensome form of hospitalization for young children. Now, of those, about 10% will be admitted to intensive care units, so quite a large number. I also just wanted to note, and they talked about this in the Wednesday session as well, so I would again recommend checking that out, that deaths are really rare, thankfully, due to RSV in high-income countries like Canada. It does still cause a number of deaths in low and middle-income countries, but thankfully, deaths among children are quite rare for all causes, including RSV in high-income countries. But that said, there are some really intensive and I would say, quite traumatic interventions that might have to take place for really severe RSV illnesses, including mechanical ventilation and more intensive forms of oxygenation, something called ECMO. So just something to keep in mind, that it can cause really quite severe illness. All right, so as you might have picked up on that previous figure, RSV tends to circulate during the winter months, and in particular, it's usually around November to April. And apologies, I think some of the figure has shifted here, but in a given year, this might differ by a couple of weeks, and depending on where you live, this might be different, but it's typically the typical cold and flu season. RSV spreads pretty easily, and reinfection is quite common. So although we think of it as a disease of childhood, a lot of the times that we have colds as adults, it might likely be RSV. For the most part, people are contagious for about 3 to 8 days, but the kicker here is that you might be contagious about a day or two before you have symptoms. So, it might be really hard to be able to prevent yourself from passing that on unknowingly before your symptoms are showing. And with RSV, it's often acquired outside of the home. So kids that are at daycare, at school, and in the case of these locations, it would be older siblings that would be bringing it home to their younger siblings that are at home. Now, I also think probably a lot of people are at this point somewhat familiar with how respiratory viruses are spread coming out of the COVID pandemic, but RSV is transmitted in similar ways. So typically one of three ways: direct person-to-person contact, so, touching, kissing, being really close contact with your baby, droplets, coughs, sneezing, and then indirect contact, such as with toys. And we know, young kids especially are not really good with this one, so it is quite easy for them to pick up RSV. Okay, a little bit about the symptoms. So the symptoms are also quite similar to cold and flu. So that's why I say a lot of the times when you have RSV, you probably might not know it, just given the similarities of timing and the symptoms. Thankfully for most of us, the symptoms are usually quite mild, and you'll get over them in a couple of days without any medical intervention. So for the most part, RSV is going to manifest as a runny nose, a cough, maybe some shortness of breath or wheezing. May or may not have a fever. So I think fever tends to be a bit more common in older kids and adults than it is in younger kids. In younger kids, you also want to be on the lookout for difficulty feeding and decreased appetite. Now, importantly, when do you think you should seek medical intervention for your child? So really, if your child is showing any signs that they're struggling to breathe, you might want to get them assessed by a medical professional. So here are a few examples. If you're seeing caving in of their chest, they're turning blue or gray, not getting enough oxygen, having short, shallow, fast breathing, noisy breathing, any pauses in breathing, flaring of the nostrils, you probably want to get them checked out. And then also signs of dehydration, particularly if they do have a fever. So, are they not wetting as many diapers? All signs that you probably want to get them assessed. And I will just note that while RSV can start quite mild in really young children and certain high-risk children, it can progress to severe disease quite rapidly. So I would say if you have any hesitation whatsoever, it would be better to get your child checked out, particularly if any of these signs are apparent. Okay, so then onto the chunk of the talk. So I'm going to be talking about risk factors. So as you might have gathered from the previous slide, young age is really, I would say, one of the most, if not the most important risk factor for determining if a child's at increased risk of severe RSV illness. The kids that are under 6 months of age during the RSV season have the highest rates of admission. I'll also note that older age on the other end of the spectrum is also a risk factor. So older adults, particularly those with underlying medical conditions. So I know not to focus here today, but we have young and older people in our lives, so just something to be mindful of. The other big one for this group is prematurity. So especially those children that are born extremely or very preterm, they're at much greater risk of developing a severe RSV illness when they inevitably are infected with RSV. So why might that be? So there's a couple of reasons, and I'm just going to bring you through a couple of the main ones. And this is a really nice figure that's on the Canadian Premature Babies Foundation and one of their resources. I would definitely suggest go checking them out. They have a wealth of resources that are really helpful. So in both of these cases, young children and premature infants, they have immature lungs. So in the case of a premature baby, their normal lung development has been interrupted. So anytime they get any respiratory infection, including RSV, it's going to be a lot more difficult for them to fight that off and to be able to breathe adequately. And in the case of the young child, their airways are just really small, right? So any type of mucus is really more likely to result in severe illness. In the case of the preterm baby, they also have less antibodies. So the longer the child is in utero, the more of those protective antibodies from the birthing parent are going to be able to transfer over to the child. So be that, the natural immunity that you're getting from, every couple of years seeing RSV and getting infected, or if you have gotten a vaccine or something else that's going to protect you from RSV or whatever other virus you're trying to protect your child from. So we see here, again, the longer the child's in term or closer to term, the more of that protection is going to get passed on. I also would note that in both of these cases for young children and preterm infants, just more generally, their immune systems are less developed, so they're going to be less capable to fight off infections like RSV. And one other thing to keep in mind is that if we have the combination of these two factors, so a child is really young during the RSV season and they're born preterm, those two factors combined are really going to place a substantial increased risk on a child's likelihood of developing a severe disease from RSV. So there's also certain medical conditions to keep in mind. So in particular, if a child has congenital heart disease and specific forms of this illness, and also if they have chronic lung disease or bronchopulmonary dysplasia, they're much more likely to develop severe RSV illness. And we know that these conditions are also more common among preterm infants, as well as a few other conditions. So cystic fibrosis, trisomy 21, or Down syndrome, those children are also more likely to develop severe RSV illness, and then as well as other really specific heart, lung, neurological, and immune disorders. So just to put some data on this, I'm an epidemiologist, so I have to put some data around things sometimes, apologies. But this is a really nice table showing that the risk of RSV hospitalization not just differs by the child's calendar age, but also whether or not they are otherwise healthy or if they have some of these conditions. So we see for the under 6-month-olds, the risk of hospitalization is 3 times greater for a child with congenital heart disease than it is for a child that is otherwise healthy. But it's 13 times greater if the child has bronchopulmonary dysplasia, and then it's about double or so for the children that are born preterm. So really a significant increase in their risk of hospitalization. Though I will note that although these conditions place an individual child at much greater risk of RSV illness, at the population level, they actually only reflect a really small percentage of the children that are admitted with RSV each year. So again, this number differs depending on a given year and where you live. But typically what we see is about only 15% of children hospitalized with RSV have any of these medical conditions. So most children, 85, 90% of children that are hospitalized with RSV were otherwise healthy and born at term. So a really important question that we have to ask ourselves then is, what are other risk factors that might be placing children that are otherwise healthy at an increased risk of developing severe RSV? So a lot of this is going to come down to social inequities. So we know, so there's many different types of social inequities that we might see, and different types of socioeconomic factors and how they might influence not just our likelihood that we're going to catch a virus, but our ability to protect ourselves from that virus and protect ourselves from getting a severe illness from that virus when, in the case of RSV, we are inevitably infected with it. So I don't have time, unfortunately, to get into all of the areas how this could play out today, but I'm just going to walk you through a couple of the main pathways how this could happen. So depending on a person's socioeconomic status, there's going to be differences in their modifiable risk factors for respiratory illness. And one example is that there's going to be differences in their exposure to allergens such as mold and tobacco in the household. So we know these things will exacerbate respiratory virus infections. And I just wanted to show you again some data from work that our team recently did looking at RSV infections in kids in Canada. So we found that depending on the type of house the child lived in, if their parent owned their home, if their house was in need of repairs, if the house was not suitable for their living situations, maybe it didn't have enough rooms for the number of people living there, the child was at substantially increased greater risk of having an RSV admission. There's also differences in uptake awareness and access to interventions. So I think, for you on the line, I think this is a big one for you to be aware of, and where you might want to be able to advocate for yourselves and the people around you. So, you now after today will know about the new products that are out there. So hopefully you can go and advocate and educate, the parents that others that about these products. But then, of course, even if you're aware, there's going to be differences in our access and our ability to go get those interventions. Do you have paid time off? Do you have good job security where you can go and get your child vaccinated, get yourself vaccinated? Are there any out-of-pocket costs that you're going to have to incur, and can you afford those? So obviously a lot of differences here. There's big differences in the risk of transmission. So if you can imagine, you live in a really crowded house, your kid's sharing your room with many siblings, much more likely to get any respiratory virus. There's also a higher prevalence of high-risk medical conditions according to socioeconomic status. So for instance, we know that prematurity is highly linked with teenage motherhood, low income, certain races, and so on. So there's a congruence of all these different factors. And just to show you some really nice data out of Manitoba, you see here that the percentage of teenage births is much higher in the low income group, so the blue line, than it is in the green line, the high income parents. And then the final one I want to talk about today is that we know that there are massive barriers in our ability to access adequate and timely healthcare. And this is particularly true, I think, in the northern parts of Canada and also really rural, parts. So, if you live in a flying community and you really can't get to a healthcare provider, maybe they're only open once a week, that situation is very different than someone that lives, let's say, downtown Toronto, where they have, hundreds of experts and hospitals at their disposal. So, once your child does show signs and symptoms of maybe developing severe illness, like how likely are you and how easy are you to get that care that they need in a timely manner is very different. So, all of these factors, I think, play out quite clearly in a really unfortunate situation that's happening in the area of Nunavik. So this is the area of Nunavut and northern Quebec, where they have the highest rates of RSV in the world. So obviously there's lots of structural and systemic reasons why this is happening. But I think this figure here that came out with one of the articles when this one study was published, I think really clearly shows, the types of living situations that might, contribute to a child being more likely to not just acquire RSV, but develop severe RSV and not get that care that they need in a timely manner. All right, and then the last thing I want to leave you with before I move on is that while we may know a lot of how these factors work with respect to other viruses like flu and COVID, there's actually not a lot of studies specific to RSV, which is really unfortunate, particularly given that RSV was discovered as a virus in the 50s, and the first paper identifying these social inequities in RSV actually was published in the 60s. So it's something that's been known a really long time in the history of RSV, but for many different reasons, it's not something that's received a lot of focus. Thankfully, that does seem to be changing in the past couple of years. So I think it's something really that we need to keep in mind, for ourselves as individuals trying to, protect ourselves and our loved ones from this virus, but also in terms of informing these new interventions that are coming out and programs and policies to ensure that we have, equitable prevention of RSV going forward. All right, and then I saw this figure in this quote during the pandemic, and I think it really applies here. So the quote here is that we are not all in the same boat. We are all in the same storm. Some are on super yachts, some have just one oar. So I think this really drives home that, we're all dealing in the same storm, but we have different resources available to us to protect ourselves from respiratory viruses or whatever other health or economic threat that we have to face. So, this poor person in the kayak is in a very different situation than the person or people that are on this massive, military vessel. And then the last thing I wanted to walk through was, again, a little bit more data. This was a study that my team did a couple of years ago in Ontario. And what we found was that depending on the child's social and social demographic characteristics, they were much more likely to be hospitalized with RSV in the first couple of years of life, depending on their situation of their family and their mother. So in particular, even after accounting for all these medical factors we know contribute to RSV risk, kids that were born to teenage moms were 50% still more likely to be hospitalized with RSV in early life than those born to slightly older moms. We also looked at different factors related to social vulnerability. So if mom had any encounters with the criminal justice system, severe mental health or addictions concerns, if she used our low-income drug benefits programs in Ontario. And again, above and beyond all those medical and other risk factors, these children were anywhere between 10 to 30% more likely to be hospitalized with RSV. And then just to put that in context of, if we could somehow prevent these additional risks in these kids, how many fewer admissions would we be likely to see? So maybe that's through, getting them a vaccine or some other type of prevention that Jessie is going to talk about shortly. But we'll start with if we could reduce the risks associated with prematurity. So if all kids had the same risks as kids that reached term, we would expect to see 9% fewer admissions. And then in contrast, if we could somehow reduce all those risks associated with kids that were born to younger moms, we would expect to see 40% fewer admissions. So a really big chunk of admissions could be prevented in this case. And sorry, I think one of the figures got a bit messy here. But just showing you how that compares with some of the other social factors that we looked at. But if we could reduce the risks associated with living in areas that are not the highest income area, we'd expect to see 7% fewer admissions. So still, quite impactful. And then with the drug benefits program, it was 4%. And just to put that in context, we saw with the preterm births, but tackling something like trisomy 21 or some of those really severe congenital diseases was only associated with like a 0.5% reduction in admissions overall, just because they're so rare. So it would be really nice if we could tackle, some of these other social risk factors to have larger benefits on RSV admissions. But what we saw was that if we really want to have sizable reductions in RSV admissions, it's great if we could tackle all these individual risk factors that we've identified. But the things that are really going to drive big reductions is if we could somehow help all of the kids that have siblings at home, or all of the kids that are really young during RSV season. So I think you'll see in a couple of minutes that thankfully this is now something that is possible with these new immunization products that we have on the market. All right, so some takeaways for you. I hope you'll see that RSV causes substantial health and societal impacts around the world each year. It's very similar to cold and flu, but it can cause quite severe disease, especially in young children, and particularly those that have certain medical conditions that are young during the RSV season. But we know that social factors are also really important, and things that we, as individuals can advocate for ourselves, but also need to be considered in programs and policies going forward, because thankfully we are on this golden age for prevention with these new products that you'll hear about soon. So I just want to leave you with this, as we go into the holiday season, we often think about, COVID and flu, but I hope you also would think about RSV prevention, this year and going forward. So thanks again. Here's my contact if you want to reach out to me, and I'll take some questions at the end of the session.
Thank you so much for that presentation. I learned a ton, and I was madly scrawling notes, and we are going to have a Q&A with you after Jesse's presentation. So thank you, and we will hear from you, some more from you later.
Thanks.
Our next guest is Dr. Jesse Papenburg, and he practices pediatric infectious diseases and medical microbiology at the Montreal Children's Hospital of the McGill University Health Center. As a clinician scientist, he works on the epidemiology of viral respiratory infections and has over 125 peer-reviewed publications. He actively contributes to national and provincial guidelines on RSV immunoprophylaxis, influenza antiviral treatment, and SARS-CoV-2 diagnostics and treatment. Dr. Papenburg is also a member of the National Advisory Committee and the Quebec Immunization Committee. We are very happy to have him joining us here today, and I'm looking forward to your presentation.
Thanks, Leah. Thank you so much for the invitation, and thank you for everybody who's attending today. It's a pleasure for me to go after Tiff. She does such great work in this field of RSV in young children, and I'm happy to see that she was able to distill that very clearly for us today. So I'm going to talk about what can we do now that you know what RSV is, what it can do, and who's at greatest risk. Let's talk about what we can do to try and prevent infection in young infants now that we're in 2025, and as Tiffany mentioned, a golden age of RSV prevention. So we'll talk about some things we can do for prevention of RSV in the home, and then we'll talk about what are the immunizing strategies that are available for infants. So we mentioned that premature babies are at higher risk for becoming very sick with RSV. Just not sure if this is the right slide. Okay, I think I just accidentally had that slide in. Sorry about that. Tiff already went over that. She talked about RSV transmission and the different ways that it can be transmitted. So direct person-to-person contact, touching, kissing, holding hands, respiratory droplets from either when we talk, we cough, we sneeze. So these travel through the air, but they don't travel very far. We're talking about 1 to 2 meters. And then finally, these large droplets can wind up on inanimate objects such as toys, doorknobs, and the like, and we can touch those objects, then touch ourselves. We touch our mucosa, so our eyes, our nose, and that's how we can also inoculate and cause an infection. We know that people who are infected with RSV typically are contagious for 3 to 8 days, and that tends to be much longer in young children. So toddlers attending daycare, because it's usually one of their first infections, so they have less immunity and they transmit for a longer period of time. We can also be infectious before we even start to show signs of illness. So that's a little bit treacherous, where you can see, oh, maybe that young child is feeling a little off, and the next day they've come full blown with a cold, and they've already been transmitting the virus from the day before. And we see that our young children tend to get infected with RSV outside the home, so in daycare, at school, and then those young children tend to bring it back home and infect not just their parents, but also, unfortunately, the most vulnerable ones amongst such, which are those young babies in the family. So what can we do to protect our young babies during the RSV season? So we know that frequent hand washing reduces the risk of respiratory virus and other viruses being transmitted in the household. Especially for babies that are at particular risk, we want to avoid crowds, other young children, and especially when we want to avoid contact with people that we know have a cold or a fever. As much as possible, let's try and keep toys, clothes, blankets, sheets clean, especially when there are other children in the house. And avoiding exposure to secondhand smoke is really important, as we know that increases the risk of not only getting infected with RSV, but having a more severe form of RSV. So I put a link there for a helpful and reliable source for prevention of RSV spread. So what do we got in terms of medical interventions? So to protect our babies from RSV? Well, now we have actually 3 different types of injections, or 3 different types of immunizations for infants. And I just want to highlight that all of these 3 types of immunizations are really what we call passive immunization. So we don't have an actual vaccine that we can give to young babies where they'll develop their own immunity, develop their own antibodies after recognizing parts of an inactive virus or that kind of train their immune system to defend itself. Because babies under 6 months of age don't tend to respond well to those vaccines. In other words, they don't develop immunity after getting those shots and that's one of the reasons why, for instance, influenza vaccination starts as of 6 months of life, because we know it doesn't work well before then, even though young babies are also at risk of severe influenza disease. So we found other ways to protect babies through passive immunity. In other words, we're going to give them antibodies to protect themselves before they are able to produce their own antibodies, and we'll protect them during their most vulnerable time, as Tiff showed, which is the first few months of life. So the first such antibody that we actually used it since the early 2000s, so over 2 decades of experience with palivizumab, also known as Synagis. It's really winding down. I think there's only 1 province that's still going to be using it this year. So this is a monoclonal antibody, in other words, a single antibody preformed that binds the fusion protein of the virus. And the fusion protein is what we call the major antigenic determinant. In other words, when you get a natural infection with RSV, you develop neutralizing antibodies against that fusion protein. It's a very important protein for the virus. And by blocking that protein, you can then block serious disease, especially getting down into the lungs. So, and that's how you can develop natural immunity to RSV. So we mimicked this by giving preformed antibodies against that fusion protein. Now, the problem with this product, palivizumab, is that, first of all, it required monthly administration during the RSV season. So not fun for parents of premature babies or other high-risk infants to have to come back on a monthly basis to either a clinic or a hospital to get these injections. We know that they worked well, these antibodies, reducing the risk by about half of getting a hospitalization due to RSV. But they had only ever really been studied in very high-risk infants, such as those with prematurity, chronic lung disease, or congenital heart disease. And we had very specific recommendations targeting only those high-risk groups because it was a very expensive product, several $1,000s per RSV season per baby protected. So it really had to be used only in the most high-risk babies. And with the recommendations and the indications for its use varied across provinces, which some people thought led to some inequities across provinces. So the same company that developed Synagis developed a new monoclonal antibody called nirsevimab. And the characteristics has two different characteristics from Synagis. One is that it binds much better, has a much greater affinity to that fusion protein of the virus. And that's because it's targeting a different conformation of the fusion protein called the pre-fusion protein. And also they made a slight change on part of the antibody that makes it last longer in the bloodstream. So the bottom line was that we get protective levels of this monoclonal antibody in the blood for over 150 days. So in other words, one shot allows prevention throughout the whole RSV season. And the dosing is such that if you're the baby's less than 5 kilos during their first season, RSV season, it's 150 milligram injection. If they're greater than 5 kilograms, it's 100 milligram injection. And there are a few indications for very high risk babies where they can get it in their second year of life or their second RSV season, in which case we give 2 injections of the 100 milligram dose. Now, how well does this work in clinical trials? So when we compared nirsevimab to placebo with over 150 days, in other words, about the course of an RSV season, we saw that it reduced the risk of medically attended RSV respiratory infection by about 80%, reduced the risk of hospitalization by about 80%, and reduced the risk of ICU admission by about 90%. And it's a super safe product. In terms of serious adverse events, no difference from placebo. And the only thing that was different was that under 1% of kids who got nirsevimab had an injection site reaction, whereas 0% of those that got placebo. So really a very nice safety profile, which wasn't surprising considering that our experience with palivizumab had also shown us that it was very safe in terms of an immunizing product. Now, the babies that already had an indication for palivizumab, you couldn't compare nirsevimab to placebo because that would not have been ethical. So what was done was they compared nirsevimab to palivizumab and found that there were no differences really in risk of RSV infection, although the study was not powered to really look at that outcome. That study really what it wanted to do was see what were the antibody levels in these high-risk groups of congenital heart disease, chronic lung disease, and extreme prematurity less than 29 weeks. And what they found was that the antibody levels were very similar to the antibody levels from the other studies that showed these reductions of 80 to 90% of RSV disease. So that was kind of our surrogate marker, or what we call an immunobridging study, to show that we have similar antibody levels to a group in which it worked really well. So that makes us believe, or at least Health Canada, the FDA in the United States, the European Medical Association, all these were the data that allowed for the product to be authorized for use in these different countries. And before Canada used the product, it was already used the year before in 23-24 in the States, in France, and in Spain, and there were real-world effectiveness studies that showed that using the nirsevimab showed roughly 80 to 90% reduction in bronchiolitis emergency department visits, hospitalizations due to RSV in places like in the United States and Europe in the 23-24 RSV season. A few things you need to understand is that the timing of administration is important because we know that it works for at least 150 days, but beyond that, we don't know. So we don't want to give it too early because we don't want the levels of the antibody and the efficacy of the immunization product to wane during the course of the RSV season. So we want to time it so that babies who are born during the season get it as soon as possible, so at the birth hospitalization, for instance, and babies who are born before the RSV season, and in most provinces they're using this, it's been 6 or 8 months. If they're 6 or 8 months of age at the start of the RSV season, they can be eligible. So these young infants can get their immunization at the same time as their 2, 4, or 6 month vaccine visit just before the start of the RSV season. So there's another way of passively protecting young babies against RSV, but this is a very different approach. it's vaccinating the pregnant person during pregnancy so that they mount a nice antibody response. They've already seen RSV in the past, so they'll recognize it and produce more antibodies against it. And then those antibodies will pass the placenta, cross the placenta, and the baby will be born with these maternally derived antibodies. So antibodies from the pregnant person to protect them during the first few months of life when they're most at risk for severe RSV disease. And just like the monoclonal antibody, over time, these antibodies will degrade and the immunity will wane, but the baby will be older and less at risk of severe RSV disease. So this is approved for use in Canada for immunization between the 32nd and 36th week of gestation of pregnancy, and it's a single dose that can be given. We know that this product works very well. It gives nice antibody levels to the baby. And what the studies have shown, both in terms of the clinical trials versus placebo, as well as in real world evidence from the United States, from the UK, from Argentina, is that it reduces the risk of medically attended RSV or severe RSV disease by about 50 to 80%. So again, very effective product, maybe a little bit less than nirsevimab, but the difference is not really that striking. And both of these products are approved for use in Canada. In the 24-25 season, what we saw was that there were two provinces that went ahead with a universal immunization program with nirsevimab, and those provinces were Ontario and Quebec, as did our northern territories have universal immunization programs. This was based on 2024 National Advisory Committee on Immunization recommendations that had a strong recommendation to build towards a universal program for all infants, including high-risk infants, but also all those term babies that do wind up getting hospitalized for RSV. And it was NACI preferred that nirsevimab be used, but they did say that pregnant people can get RSV pre-F based on a conversation with their healthcare provider, but did not recommend RSV pre-F public health programs for RSV prevention, preferring nirsevimab. So that's how Ontario and Quebec went ahead with their programs for all babies who are born during the first RSV season or less than 6 or 8 months of age at the start of the RSV season, as well as specific high-risk groups in their second RSV season. And in Quebec, our Institut National de Santé Publique du Québec evaluated our program implementation. So it started in October, but we had supply issues, and unfortunately only a few doses came in at that point, and we prioritized our high-risk babies. Then the full-blown program, the universal program with the catch-up, so babies born during the season and catching up for those young babies at the start of the season, started in November and ran until March of 2025. We administered over 50,000 doses. We had roughly 67% coverage, which is not bad for a first year of an implementation. And that coverage was higher among newborns, and almost all of those babies got their dose during their birth hospitalization. And we had about 50% coverage for catch-up. In other words, babies that had to book an appointment at a clinic or another immunization center. We also looked at what was the risk of RSV in babies who got nirsevimab compared to those who didn't, in what we call a test negative design study. And what we saw, the field effectiveness in Quebec was really, really good. 80% less chance of going to the emergency department due to RSV, being hospitalized due to RSV, 89% reduction, and 88% reduction in ICU admissions due to RSV for babies who received nirsevimab. And that translated into about a 60% reduction in RSV admissions overall versus what we would have expected amongst babies under 6 months of age. So that we estimated that roughly, again, this is a little bit less precise because we did have to try and model this, and it's kind of trying to compare it to what would have happened had there been no immunization program. But we expected it probably prevented about 1,000 hospitalizations and 100 ICU admissions. In Ontario, they also had a successful implementation with newborns getting a lot of doses in hospital, a lot of pediatricians' offices and primary care offices administering doses as well. So the way it was distributed was different in Ontario compared to Quebec. But the bottom line is that the total coverage was about 70% of all eligible infants in Ontario received nirsevimab, and it was about 4% of infants that were protected through maternal vaccination, because Ontario also publicly funded maternal vaccination, but prioritized the use of nirsevimab. And looking forward, this is a table from Sarah Buchan and Tiff Fitzpatrick at ICES and other colleagues that put together a research proposal to look at what are the, considering that there are differences across provinces for the use of different immunization products, how can we then use those differences in programs to try and see what the benefits are of those programs. So hopefully that's work that's going to be moving forward next year. But this little table gives you a sense of, last year there were very few provinces that had in which nirsevimab was available for all infants. It was only Ontario and Quebec, along with the Northwest Territories, Nunavut, and the Yukon. But this coming year, other provinces have come on board with the universal immunization program. Nova Scotia, Prince Edward Island, Saskatchewan have universal programs. And Alberta, British Columbia, Manitoba, and New Brunswick have switched away from palivizumab or Synagist and now have nirsevimab, use nirsevimab for their high-risk babies. And it's only, I believe, Newfoundland that still is using palivizumab this year. These data are from September, but I don't think there's been any changes since then. So I'm going to conclude by saying that there are everyday things that we can do to protect ourselves from RSV. And now we have two very highly effective ways of preventing RSV in young babies. We have injections that are antibodies against RSV that are available for high-risk babies in some provinces, all babies in other provinces and territories. So be on the lookout for your provincial recommendations. And there's also maternal vaccination that is available across Canada at a cost and free of charge in Ontario. So two very different ways to protect our youngest and most at-risk population from RSV, which is the leading cause of hospitalization in kids during their first year of life. So I'll end there with putting up there some reliable resources that can be found on the web. I invite you to go see those if you want to learn more about prevention of RSV in infants.
Thank you so much for that presentation. I'm inviting Tiffany back to the stage as well so we can open up the discussion. If anyone has any questions or comments, just pop them in the comments section. I know that this came up at our webinar earlier in the week, and we didn't get to it, although people were answering this in the comments, about the two kind of the, I believe you call it the pre-F, RSV pre-F, the maternal vaccine, and the other vaccines, whether it's nirsevimab or the one that starts with P that I can't recall at the moment. But are both of those, like, if you can access both, should you be using both? Or are we looking at, if you get the RSV pre-F, do you need to then worry about the other injection for your baby? Or what's the preference? Why should people, how do we weed through that information as members of the public?
Right. So I would say that, first of all, again, as I mentioned, the vaccination during pregnancy, so with the RSV pre-F, it's available across Canada, but at a cost. And we're talking probably around $250 for that one injection. So it's unfortunate that there's only certain people that are going to be able to afford that type of protection should families or expecting parents want to go that route. So it's available across Canada at a cost, with the exception of Ontario, where it is covered by the publicly funded program. But nirsevimab in the provinces that have it for all babies or for high-risk babies it's given directly to the infant. Now, should you do one or the other? I think there are some pros and cons for both of them. I think some of the cons for vaccination during pregnancy is that you're relying on that transfer of antibodies across the placenta. So that actually takes 2 weeks. So there needs to be 2 weeks between the injection and birth for baby to have gotten all of those antibodies. The other things that we know that, as Tiff mentioned already, that babies that are born prematurely get less those antibodies. So a baby that was born prematurely or in whom those 2 weeks had not elapsed may not be protected from the maternal vaccination. And most provinces do then therefore recommend that these babies also get nirsevimab. Most provinces also, in very high-risk babies, if there was maternal vaccination, they'll recommend getting nirsevimab as well. However, in otherwise healthy term infants, the added benefit of doing both is thought to be so marginal that it's not recommended. So we don't think that it's worth, certainly not from a public health perspective or from a program perspective, to be double immunizing infants that are born healthy at term, at least 2 weeks after the maternal injection, not premature. Like the maternal vaccination would be considered sufficient.
What shocked me today, because I have 3 girls, and 2 of my 3 girls have been hospitalized with RSV. One of my babies is a preemie. My middle child is asthmatic, and both of them were in PICU and then our medical floor for a number of weeks. And I didn't realize how much this can affect term healthy babies. Looking at the numbers you were presenting, Tiffany, and you talked about the studies and how, we've known about RSV for a long time, but there haven't been many studies on it. So it seems like it is a large issue and quite a burden on our healthcare system. So why has it been kind of ignored when it comes to studies?
Oh, that's a great question. So I think just like generally social inequities do not get a lot of attention, unfortunately. So I mean, a lot of the attention for RSV, like rightfully so, has been looking at those medical risk factors and understanding interventions like palivizumab in a clinical context. So, for various reasons, you're only going to enroll really specific like medical conditions in those studies. But I think in more recent years, and especially coming out of the pandemic, I think there is an increased appreciation for the role that social inequities have. And I think in the case of RSV too, like there's been an increased recognition that, okay, while an individual child with, prematurity or congenital heart disease or lung disease is at increased risk, they're only 15% of the admissions, give or take. So, what is this other chunk of children? But in the past with palivizumab, we couldn't really effectively help those children, unfortunately, because that program was so limited. So now that we do have these new products, like it's finally, I think, feasible and time that we can start addressing some of these other factors through immunization and, the equitable delivery of those programs. And on that note, one thing I would say for the first question that you asked is that if you do unfortunately live in one of these provinces where you don't have the universal nirsevimab program, the maternal vaccine is much cheaper option. So if you're paying out of pocket for both of these products, nirsevimab costs about 3 times more than the maternal vaccine. So that might be something that you would want to look into, especially if you don't have supplemental health insurance and you're paying out of pocket. Like these are, real, I think, issues that people are facing when they want to get these products that, unfortunately are not covered.
Mm-hmm. It's shocking to me the amount of provinces who don't have the universal program yet. And I'm wondering if they jump on board in a hypothetical, is this something that we would have supply enough for all vulnerable and term, all babies, I guess, under 8 months would become the universal recommendation? Would we have enough to do that in Canada?
Yeah, so the way that procurement, or how do we purchase vaccines, actually happens way in advance. So probably in the month of January is when those contracts get negotiated between either the provinces or Procurement Canada and vaccine manufacturers for vaccines that are given seasonally during the winter, so influenza or COVID or RSV vaccines. So these things get planned way in advance, and provinces need to then plan to say, okay, well, expecting to purchase this many number of doses. And Procurement Canada or through a contract directly between the province and the company, they'll get those doses. So I'm not concerned about the supply at this point. In the first season that it was available, there was very limited supply because unexpectedly the United States came on board right away with the universal vaccination program, and a lot of doses were going to our neighbors down south. But since then, I think supply has stabilized and it would not be an issue. The main issue with nirsevimab, it works really well. Like reductions of 80 to 90% of these severe outcomes. It's amazing. Like it's really incredible. It's super safe. There are really no safety signals that have been raised at all. So what's the hang up? The hang up is the cost. And it is, even though depending on what that cost is, it can be cost effective for the healthcare system and an efficient use of resources, depending on how you use it and how much it costs. But it still is a budget. There has to be a line budget of the province's Ministry of Health that can provide those funds. And there, each province has a lot of babies that are born, and each of these individuals with a substantial cost. So I think with time we will see more and more provinces coming on board, but the cost has been the major issue up until now.
It still feels weird to me, and maybe it's because I don't understand economics at all, but that we're talking about hospitalized kids and sometimes 2 and 3 weeks. And when you look at that as being the cost, wouldn't it be more cost effective to have that budget line in there for those many babies who are hospitalized every year in that province?
I don't know, Tiff, do you want to answer that, or I can? There are economic analyses that can be done by health economists and experts in both the disease and how much the consequences of what the disease, what that costs, comparing to the cost of the prevention, and then we have metrics to say what is cost effective. In other words, an efficient use of our healthcare resources, which unfortunately are limited, and what might not be cost effective. So there are these analyses that have been done at the Canadian level, different provinces, or at least I know Quebec has we've done our own analysis for that as well. And a lot of the most important variable for this intervention to be cost effective is how much does each dose cost. So it comes down to the negotiation process and where each province will feel that, okay, I'm willing to pay that much, because there are benefits, but we want to make sure that we're getting the benefits that we're getting are worth the money that we're investing in it. Because if not, that means that there's something else that maybe more cost effective that we're not able to prevent or treat. There are other vaccines as well that have been shown to be cost effective that provinces have not been able to roll out yet, because just a question of finding the money.
Mm-hmm. Talking about social attitude toward RSV in general, we talked about how for a lot of people it presents as a cold. And I know, there's some families who have had young kids who are just kind of shrug it off saying, well, it's just a cold. Why would we want all babies vaccinated for this number? It's kind of like the same COVID discussion that we had, right? To protect the vulnerable. And so how do you think we can change that conversation or that attitude, or do we need to when it comes to the RSV vaccine?
Maybe I can take a first go, Jessie, and then you can jump in. So I personally would point to that year we had like 2 years ago where RSV, it kind of went away during the pandemic because masking and school closures and all those things, reduced all viruses, not just COVID. But when it came back with a boom. Like, it was overwhelming all of the hospitals. And I think a lot of people really, probably for the first time, noticed RSV as a virus and saw like how severe it could be. So I'm hoping that would be, a good justification for people to understand why they'd want to go get vaccinated. I mean, it does place considerable burden on not just the health of children and their families, but also the healthcare system, right? So during the cold and flu season, RSV is really the reason why, there's huge waits in the ERs, and why, the hospitals are at capacity with their pediatric beds. So I think what we're seeing last year is that these new products really reduced all of those emissions and that disease due to RSV, so that, we can free up, hospital resources, the dollars to spend on other things to improve child health.
Yeah, and I would just add to that these are things that Tiff already mentioned, but they're so important. Number one is that 85% of babies who wind up in the hospital due to RSV have no underlying medical condition or known risk factor. The only risk factor is that they're a small baby. They're vulnerable because their airways are small. They don't have the immunity yet. That's why they're just small babies, and these are the babies we want to protect. So that would be, I think, and it's so common. It's the leading cause of hospitalization in the first year of life in Canada. It's the number one cause that babies end up spending the night in the hospital. And again, it can happen to any baby. So that's the way I kind of frame it, that for us in pediatrics, it's bread and butter. We see it all the time. Mm-hmm. And frontline pediatricians who worked in the emergency room or on the pediatric wards, they felt the difference last year in Quebec with our nirsevimab prevention program. They said there are fewer young babies being admitted to RSV. Normally we see it all the time, every day, 3, 4, 5, 6 admissions in one hospital due to RSV in young babies. And they didn't completely disappear, but pretty close to it.
Mm-hmm. It's incredible. We're going to say goodbye for today, but just wondering if either of you have anything you want to add in terms of advice for families as they're navigating. We're really coming into that RSV season now, and it does create feelings of fear, especially for those of us who have had vulnerable infants. And so just wondering if you want to leave our families with any advice as we come into this season.
I would say, first of all, just, there are certain things that we can control. So get informed on the ways that you can reduce the risk of RSV in your baby, especially if it's a high-risk baby in the home, and what is offered in your province, either if you're expecting a baby to be delivered during RSV season or have a young baby that was just recently born, in terms of prevention, to make sure that you avail yourself of that protection if it's available.
That would be my message too. I mean, I had a baby last October when these programs were coming out, and I was, I had the awareness, so I was out there advocating to get everything. So I would say to you on the line, like, you now know about this, so make sure you go out and advocate. Let other people that you know in your lives know that these products are out there and that they can prevent RSV quite effectively.
Well, thank you so much again, both of you, for joining us here today. I learned a ton. I hope that those viewing also learned some, and that we're able to, again, continue this conversation and carry forward the advocacy so that every baby can be protected in Canada. Thank you. And thank you, everyone, for joining us here today for today's episode of Preemie Chats. A special thank you to Sanofi for their support of educational programs such as this one. And if you missed part of today's episode, or if you want to revisit it, you can find this episode and all of our past episodes on our YouTube channel and website, CanadianPreemies.org. And while you're there, explore the many free resources and support options we offer to help families on their journey. As a charitable organization, CPBF relies on the generous support of people like you. Your donation allows us to continue empowering families of premature babies every step of the way. Together, we can create a brighter future for all preemies and their families. And speaking of brighter future, you're almost going to be missing out if you don't have your tickets yet for the Little Lights, Big Hearts Gala that's taking place beginning of November 6th in Toronto. I know there are very few tickets left. And so if you haven't already jumped on board, Don't miss it. It's going to be a tremendous night of just delicious dining, memories, amazing auction. Some incredible items have been donated. And of course, lots of purple, because that is our color. And we are all a community of people who love our babies and want to see them thrive. So join us if you can. We also have virtual options. So if you're sitting here thinking, there's no way I can get to Toronto for that gala, you don't have to be left out. Keep your ear to the ground. We have lots of virtual ways you can take part in our gala. Thank you so much for being a part of this community. We will see you next Friday at 1 p.m. Eastern for another live episode of Preemie Chats.